Okay, looks like we're gonna get started. We have quite the attendance this quarterly, so thank you all for coming. So just an introduction, hello, my name is Rola, and I am the Vice President of Events for Students for Global Health at UCSD, and I wanted to say thank you for attending our winter quarterly Conversations in Global Health. Please note this event will be recorded and posted online, so you will have access to the recording. Before we begin, I wanted to highlight some upcoming global health events. We hope to see you at these future events taking place that are related to global health. Students for Global Health is having a UNICEF sticker fundraiser. So students are raising money to donate to UNICEF for COVID relief. We kindly ask for your consideration to donate to support to children around the world during this time. For those interested, we will post a sticker order form in the chat. And Colette will be talking a little bit more about this in a few. And then we also have the Latinx, Chicanx, and Global Health Mentorship Hours, which is new. These mentoring sessions are open to discuss fieldwork experiences, challenges, research methodologies, decolonial perspectives in global health, preparing a personal statement, a CV for grad school, and many others addressing particular interests from the Latinx, Chicanx students in the global health program. So these sessions are on from Thursdays at 3 to 5 p.m. So please see the latest Global Health News Blast for more information. Additionally, for those in global health courses that are receiving extra credit, there will be online sign-up sheets posted in the chat to sign in once the event concludes. I would like to bring up this afternoon's MC and the Global Health Program Director, Dr. Thomas Shordash, to the stage.
And quite a stage it is. I am Dr. Tom Shordash, Director of the Global Health Program and Professor in the Department of Anthropology. Welcome to Winter Quarterly Conversations in Global Health. Quarterly Conversations is a recurring event at UC San Diego made possible by the Global Health Program, Students for Global Health, and the Global Forum. As with all our events, the goal is to bring the global health community and the local San Diego community together to discuss important issues in the field. Though we're forced into the technological solution provided by Zoom, we also have to acknowledge the unintended benefit of being able to reach a much wider audience than with our usual live events. Before we begin, let me express special thanks to our co-sponsors and individuals that have made these events possible this year. We'd like to thank first the Global Health Institute, the Center for Global Mental Health, and the Global Health Program for providing support and sponsoring this event. We'd like also to give a huge thank you to the community and student organizations tabling virtually here today for spreading knowledge and resources on such an important topic. And I have a screen that wants to send me away so that I can't see you. Special thanks to the events committee, led by Global Health student Rola Kojak, and comprised of board members from UCSD Students for Global Health, as well as our Global Health advisor, Erin Warren, and our program coordinator, Brittany Wright, who all contributed in putting together this afternoon's conversation. Given the extra challenges, I want to make certain that we give abundant thanks to Brittany and Erin, and not only for this event, but for everything they do to keep the program strong and moving forward. Finally, we'd like to welcome our guests from Aya Healthcare and thank them for their interest in the Global Health Program and its mission to promote global health equity through education. Before we get into hearing from our panel of speakers, we'd like to begin the event today by highlighting some of the organizations on the UCSD campus and in the greater community. In our usual quarterly conversations format, our tabling organizations are set up in booths at the physical event, explaining how their work is related to the topic at hand and providing resources on how to get involved. Because of the nature of this virtual event, we'd like to invite our tabling organizations to speak for a few minutes and share a bit about the work they do and the work they are doing to provide support services and foster community for undergraduate and graduate students. First, we'd like to invite Shiana Gideon to speak about the Black Resource Center and the services that they provide to students, alumni, and the community.
Hi, everyone. Thank you for having me. Give me one moment. I'm going to share my screen. Sorry. Oh, here we go. Okay. Can everyone see that? Okay, perfect. So let me introduce myself. My name is Sienna Gideon. My pronouns are she, her, hers, and I'm an intern or student success intern at the Black Resource Center. This is my first year doing it, but I'm a second year at UCSD, and I reside in Muir College. So just to start off, the Black Resource Center, as you can see, is a home away from home. We like to provide a community for the Black students at UCSD. Anyone is welcome into the center and to our virtual events and events in person eventually as well. So I'm just going to introduce you to some of the staff. So we have Portia Curry, who is our director of the Black Resource Center. She's basically just in charge of running the center and hiring the interns and making sure the center goes smoothly as possible. And then we have Kyler Nathan, who acts as the facilities, operations, and event coordinator in the center. And they're both UC San Diego alumnus. And then I want to go ahead and introduce you to the long list of the Black Resource Center staff. These are interns. We have peer guidance interns, as well as student success interns and transfer student success interns. And we have also some positions for graduate students in the center as well. We all work together to plan events, to reach out to community, promote events going on in campus, sending you resources your way, and overall just help form that community as Dr. Thomas was stating, forming a community for the Black students. So this is the pictures of the Black Resource Center physical space. So we can't be there right now. It's very much missed. As you can see here, I'm not sure if you can see my mouse, but the first two pictures you're seeing is called the family room. This is the space where we mostly hold events. This is a space that we also hold virtually right now, where students can just come in, talk, a space to study. That's usually what it's used for. There's always discussions going on in there. And it's just a time to, relax and be around students that look like one another, because you might not see them around on campus. And it's in the second floor of the original student center, and it's above the general store area. So programs and events. So the Black Resource Student Success Series, this is where the interns like myself, we host many programs on campus, and they're all beneficial to help students get, I was mentioning earlier, resources on campus. We have a welcome week every year. We do, I can't remember the name of it right now, but we usually have like a sleepover kind of thing for prospective Black students to come on campus, get a chance to meet other Black students, to get a chance to see the campus and explore the campus. So the Student Success Institute and the mid-year mixers, which we do have virtually as well, and we just held one a couple weeks ago. So the peer guidance program is just designed to aid the academic, social, and cultural adjustment of incoming Black students to life at UC San Diego. This is basically where they're paired together and just create that community, as I want to emphasize again. And then we have the Black graduation ceremony. Everyone can't wait to the day they graduate. And so we like to definitely honor our Black students on campus, because this is it's just an honor to be a Black student. And it's just something that we need to highlight, that it's, this is a different, not many Black students have access to to graduating. And so we want to make sure we highlight that, and that you get a chance to celebrate with the Black people on campus, other Black students, other Black graduates, and alumni. And then community programming. So as I was mentioning before, we host all kinds of events. I'm actually hosting 2 events this weekend, collabing with the other Black resource centers at in the San Diego area, so at University of San Diego, and San Diego State. And it's just events where, again, we're creating that community, we're giving you your resources, we're providing you with time away from work to just rest and relax. And we host all kinds of programs. So definitely check that out. And you'll definitely get some of our information at the end as well. Okay, so we also like to show you some of the Black student organizations on campus where, again, you can get those resources, get those things that you might need on campus and create that community for yourself. Just to name a few, the Black Student Union, very popular on campus. They host their meetings every Monday. Black Geek Collective, all kinds of events and opportunities for Black students to be involved, to have their resources, have that community, just a space for you to be your own person, in your, sorry, excuse me, just to be a part of community. And then next, connect with us. So on this screen, you'll see the website, brc.ucsd.edu. This is where you can sign up for our newsletter. This is where you can sign up and apply. You can also apply for some of the positions on the campus. You can see what's going on in the BRC, what's new, what's happening. And you can also email us for any comments, concerns, questions you might have. To be also, you can add your events and things, or request to add your events into some of our newsletter to spread across to the students on campus. You can also find us on social media. So our Instagram, our TikTok, our Twitter will all be at UCSD BRC. We're always welcoming new students. We're always trying to find the best ways to promote things going on campus. We have on our newsletter, we have a place for UC San Diego community and events. That's where you'll find things that the Cross Cultural Center might be hosting, that other places on campus might be hosting as well, and just those resources, scholarships, all of that on there. So go ahead and take a look at that if you can. And thank you for having me.
Thank you, Sienna. Next, we'd like to invite Dr. Jessica Graham from the Black Studies Project Collaborative to speak.
Hi, everyone. Thanks for having me. I'm going to share the flyer that we've prepared. So I am Jessica Graham. I'm director of the Black Studies Project here on campus. And so before I get to the information on the flyer, I just want to give you all a little bit of background information about the Black Studies Project, or the BSP as we refer to it as, what we do and what kind of opportunities we try to create for students and faculty on campus. So essentially the Black Studies Project is a research collaborative with 3 key areas of research. One is intersectional analyses of race, class, gender, and sexuality. The second is transnational and diasporic studies. And the third is social justice movements. And so our goal is generally to foster, nurture, strengthen, and grow an intellectual community on campus around these and other areas of Black studies, and also to create opportunities for stimulating conversation around the social justice issues that affect Black and therefore other communities, right, in San Diego and the nation and worldwide as well. And so in terms of, creating the intellectual community and fostering these kind of conversations, this is largely done through a number of public events that we hold every year. Our next event should be on March 11th. That will be on police abolitionism in praxis and theory. So if you hear all these conversations around these topics and issues that are very timely and are kind of hot topics that people are trying to understand and think through in terms of what our society should and could be, if you're curious to know kind of what are the theoretical frameworks and how folks act as activists work around these frameworks, that this might be a good event for you. So check out our website if you would like to learn more about that. And we also hold smaller seminars that are just for graduate students or that include Black Studies faculty and graduate students as well. Another thing that we do is we set out to encourage and support those on campus who would like to work, who do work or would like to work on research that deals with the lives, experiences, and the social, cultural, political, and economic factors that affect Black communities. And that includes, of course, public health. And so that takes me to the flyer that I've created. Oh, I don't think it's shared. Is it shared? Sorry, I think I was sharing something. I didn't, usually there's a green border around the flyer. Okay. So the flyer, essentially what I try to do is think about some of the projects that we have in mind that we would like to do if there were folks on campus who are interested. I should say in terms of our three kind of main pillars of research foci, we have always wanted to include STEM and public health as one of the legs on which our research really focuses on in terms of the Black Studies Project and its work. So some of the things that we're discussing in terms of potential possible collaborations with Black Studies faculty and folks who deal in the field of public health would be forming a public health research group that focuses on the Black community. For instance, we have faculty who are interested in questions around reproductive rights and justice. Another topic could be community-based work that addresses public health and policing. So for instance, there's a lot of interest around decriminalizing mental health. So those are, just a couple of ideas that might be resonate with some of you out there. But in terms of kind of generally, if those of you graduate students or faculty are interested in becoming involved in the BSP in terms of the initiatives that we already have or those programs that we're about to begin in the next academic year. You might be interested, for instance, in our graduate fellowships, grants and support programs, which includes dissertation fellowships, travel and research grants, and graduate student seminars, and also writing retreats for graduate students. We also, if there's faculty here, have faculty fellowships that's intended to help ladder rank faculty on campus make significant progress on some research project. And in terms of undergraduate research internships, we are about to start next year a new internship program for undergraduates that will be every spring quarter and will go into the summer. And in the spring quarter, it will be a course that will be offered through the African American Studies minor, which will hopefully by then be a major. And you'll have a cohort of groups in which you will learn methods in, or research methods in Black studies. And then in the summer, there's an 8-week research internship in which students can begin to work on projects of their own design, research of their own design. And you'll have 8 weeks to conduct and complete that research, and it's a paid internship for $2,000. You will be given a faculty mentor as well. And it's really meant to kind of create a research environment in which students get the training they need to do the research, but also have a cohort of other students engaged in similar topics. So you have an experience of doing independent and individual research, but also being in having a collective research experience and guidance as well. Finally, I'll end with this, which is we are also very excited to be starting next year our Social Justice Fellowship, which will bring onto our campus every year, perhaps every quarter, a Black community organizer, activist, or artist who's engaged in the Black community here in San Diego. So it's an opportunity for students to become engaged with folks who are doing really important work or engaged in cultural production in San Diego, and they'll be coming to our campus so that students can interact with them and can engage in some sort of collaborative projects with them. And this is, we're happy to say, is a paid position that we're offering to folks in the broader San Diego community. So also, if you know of anybody who think might be a good candidate for this, please contact us. So as you see at the bottom of the flyer, you can visit our website, bsp.ucsd.edu, or send us an email at bspucsd@gmail.com. Okay, and that's it for me. Thank you.
Thank you very much, Dr. Graham. Lastly, I'd like to invite Colette Kirkpatrick, President of the Students for Global Health, to speak about their organization.
Thank you, Dr. Shordash. Can everyone hear me? Is that okay? Okay. Hi, I'm Colette. I'm this year's president for Students for Global Health. I use she, her, hers pronouns. And before I begin, I just want to thank the Students for Global Health Events Committee, Rolla, Aaron, Dr. Shordash, and all of our amazing speakers. We couldn't have asked for a better panel today. But I want to talk a little bit about Students for Global Health. And here at our org, we really aim to bring together students from all different backgrounds and majors that are passionate about global health topics. And the field of global health is super interdisciplinary. So we talk about a range of topics from climate change to racial inequities to women's health, because we understand that all different parts of our identities and where we come from affect health and our access to healthcare. We host GBMs on topics like field experience, masters in global and public health, and we really just want to connect our students to the opportunities that will help them in their time at UCSD and also in their career in the future. We also organize fundraisers, like Rolla said. Right now, we have our UNICEF fundraiser going on right now, and I think the link is still in the chat, but if you sign up, buy your sticker, you can Venmo Students for Global Health. They'll mail the stickers to you and they're super cute. So I highly recommend everybody check them out if you want one. And then if you're interested in becoming a member, we also have a link in the chat as well. So you'll be added to our email list and notified about all of our different events. We also have board member applications opening in the spring. So if you're interested in planning GBMs on different topics, giving your input, or planning events like the quarterly we're having today, raising fundraisers, or doing external outreach, we have a lot of positions opening up in the spring, but we'll be giving out more information if you sign up using the membership link. That's all I have for everybody, but thank you so much for having me, and thank you to all of our speakers.
Thank you to our tabling organizations for all the work that you do and have been doing during this unprecedented time. Racism is a global health crisis, one that leads to devastating health outcomes for the Black community. Black Americans experience high levels of stress due to racism in their daily lives and have difficulty obtaining health insurance and accessing high-quality healthcare services. This leads to poorer health outcomes when compared to other Americans. The recent events of 2020 have further illuminated the health effects of systemic and structural racism. This was not only reflected in the inhumane acts of murder and violence against George Floyd, Breonna Taylor, Ahmaud Arbery, and countless other Black individuals, but also in the disproportionate rates of COVID-19 cases and deaths throughout the Black community. We are vividly aware of the recent struggles of the Black Lives Matter movement, but also that the inequities faced by the Black community extend back at least 400 years to 1619 with the Middle Passage and enslavement. When we, as members of the global health community, adopt the imperative of promoting global health equity, by equity we mean both equal access to healthcare and ultimately equal levels of health and well-being for all people. By global, we mean everywhere around the world, but we emphatically include the United States and our own underserved regions and communities. So how can we pursue racial justice and social justice in healthcare when the disparities are deeply ingrained in the system itself? We're privileged to have 4 distinguished panelists with us to share their expertise and experience as we explore this question. Our speakers today are Dr. Sandra P. Daly, Professor of Pediatrics and the former Associate Chancellor and Chief Diversity Officer at the University of California, San Diego. Dr. Rodney Hood, President and Chairman of the Multicultural Health Foundation and past President of the National Medical Association. Michelle Talley, LCSW, from the UCLA Luskin School of Public Affairs Field Education. And Dr. Seth Hannah, our own UCSD Global Health faculty and the academic coordinator of our Master of Arts in Global Health program. Each of our speakers will get 10 to 15 minutes to introduce themselves and present. Our first speaker is Dr. Sandra P. Daly. She's Professor of Pediatrics and the former Associate Chancellor and Chief Diversity Officer at UCSD. As the UC San Diego School of Medicine's first Assistant Dean of Diversity and Community Partnerships, she and her team received the California Wellness Foundation Champion of Diversity Award for establishing a housing and urban development funded community/university partnership center, an elementary school-based clinic and 2 programs that are now institutionalized and available for students at the University of California, San Diego School of Medicine. This is the Prime Health Equity MD Master's Program that prepares students to work with populations at risk for experiencing health disparities and the Conditional Acceptance Post-Baccalaureate Program, the first post-bac program in the UC system that guarantees admission to medical school. In addition, Dr. Daly and her team obtained funding from the Health Resources Services Administration and the National Institute on Minority Health and Health Disparities to design and conduct academic enrichment, research training, and peer faculty mentoring programs for community college transfer students, undergraduate and medical school students, and junior faculty. Before joining the faculty at the School of Medicine, she was a medical director and executive director of the Comprehensive Health Center, a community health clinic that serves low-income African American and Latino families in Southeast San Diego. She's an alumna of UC San Diego School of Medicine and the Kellogg Foundation National Fellowship Program. Dr. Daly is of Afro-Latina heritage and was born in Panama. Please give a warm welcome to Dr. Sandra P. Daly.
Good afternoon, and thank you very much. I would like to say before I start that some of the most recent work in the literature review on this subject was conducted by my UC San Diego undergraduate student, Jahan Ezuddin, as part of her ongoing research project. The next slide, please. When addressing health in the Black community and in other underserved, disadvantaged communities, you're dealing with the impact of the social determinants of health. Slavery, genocide, classism are economic constructs designed to ensure that the rich get richer and that make the poor get poorer. The social environment and economic systems determinants are alive and well in our country and all over the world. Racism is a justification for perpetuating these economic constructs. Next slide, please. The other social determinants of health include the physical environment where we live and work, and the next slide. And of course, health services. Do we all have access to quality healthcare services? How do we pay for it? How do we fund health services? And how is it regulated? We see poor health outcomes in all communities that are oppressed, disenfranchised, or marginalized. Work on any of the social determinants is work that gets us closer to achieving social justice for all of us. Social justice is the overarching mission, and to achieve it, all of us with our diverse backgrounds, knowledge, and talents are needed to do the work of creating conditions where people are born, grow, live, and thrive before they die. Acts motivated by racism, acts of genocide, persistent poverty, difficult physical environments, lack of health care, and more create conditions that are making us sick. We're all living in environments that are chronically stressful. Those of us who are being victimized and abused are stressed out, and those who are perpetrating the abuse are stressed out. We're all experiencing the consequences of this unfair and unjust society that we live in. Next slide, please. And will you start the link?
Can affect brain size,
Oh,
its
yeah.
structure.
Sure, I'll start it over from the beginning.
Are you sleeping restlessly, feeling irritable or moody, forgetting little things, and feeling overwhelmed and isolated? Don't worry, we've all been there. You're probably just stressed out. Stress isn't always a bad thing. It can be handy for a burst of extra energy and focus, like when you're playing a competitive sport or have to speak in public. But when it's continuous, the kind most of us face day in and day out, it actually begins to change your brain. Chronic stress, like being overworked or having arguments at home, can affect brain size, its structure, and how it functions, right down to the level of your genes. Stress begins with something called the hypothalamus pituitary adrenal axis, a series of interactions between endocrine glands in the brain and on the kidney, which controls your body's reaction to stress. When your brain detects a stressful situation, your HPA axis is instantly activated and releases a hormone called cortisol, which primes your body for instant action. But high levels of cortisol over long periods of time wreak havoc on your brain. For example, chronic stress increases the activity level and number of neural connections in the amygdala, your brain's fear center. And as levels of cortisol rise, electric signals in your hippocampus, the part of the brain associated with learning, memories, and stress control, deteriorate. The hippocampus also inhibits the activity of the HPA axis, so when it weakens, so does your ability to control your stress. That's not all though. Cortisol can literally cause your brain to shrink in size. Too much of it results in the loss of synaptic connections between neurons and the shrinking of your prefrontal cortex, the part of your brain that regulates behaviors like concentration, decision-making, judgment, and social interaction. It also leads to fewer new brain cells being made in the hippocampus. This means chronic stress might make it harder for you to learn and remember things, and also set the stage for more serious mental problems like depression and eventually Alzheimer's disease. The effects of stress may filter right down to your brain's DNA. An experiment showed that the amount of nurturing a mother rat provides its newborn baby plays a part in determining how that baby responds to stress later in life. The pups of nurturing moms turned out less sensitive to stress because their brains developed more cortisol receptors, which stick to cortisol and dampen the stress response. The pups of negligent moms had the opposite outcome, and so became more sensitive to stress throughout life. These are considered epigenetic changes, meaning that they affect which genes are expressed without directly changing the genetic code. And these changes can be reversed if the moms are swapped. But there's a surprising result. The epigenetic changes caused by one single mother rat were passed down to many generations of rats after her. In other words, the results of these actions were inheritable. It's not all bad news though. There are many ways to reverse what cortisol does to your stressed brain. The most powerful weapons are exercise and meditation, which involves breathing deeply and being aware and focused on your surroundings. Both of these activities decrease your stress and increase the size of the hippocampus, thereby improving your memory. So don't feel defeated by the pressures of daily life. Get in control of your stress before it takes control of you.
I want to point out that the World Health Organization reports that depression is the leading cause of disability worldwide, and Alzheimer's ranks as number 7 of the top 10 leading causes of worldwide deaths. Next slide, please. That's the slide. No, that's the one. Thanks. As an example of work in health services, one of the social determinants of health, I will describe 2 programs, and I hope I have enough time. My team and I designed these programs to address access to quality healthcare, specifically promoting diversity and equity and inclusion in the healthcare workforce. The UCSD School of Medicine Conditional Acceptance Post-Baccalaureate Program, which Dr. Shortis already mentioned. The program selects students who have demonstrated a commitment to working with populations at risk for experiencing health disparities, but their advocacy and the time investments that they put into this work during their undergraduate school years led to academic underperformance. And the UC San Diego School of Medicine program in medical education, health equity. a dual degree MD master's program designed to develop clinician scientists and clinician advocates prepared to eliminate health disparities in their communities, our nation, and the world. Both programs are institutionalized because we recognize that successful programs must become part of the organization in order to create systems that are so flexible and so responsive that problems will simply dissolve. Successful programs are also adaptable, and UC Irvine now has a conditional acceptance post-baccalaureate program modeled after ours. Next slide, please. The conditional acceptance post-baccalaureate program has a $2 million endowment. Since 2002, 73 students have enrolled in the conditional acceptance program. 43 have completed medical school, 18 are now in medical school, and 5 are currently enrolled in the program. The conditional acceptance post-baccalaureate program is addressing access to care. Next slide, please. 70% of graduates are practicing in a primary care specialty compared to 34% of medical school graduates nationally. 70% of graduates are practicing in health professions shortage areas, medically underserved areas, and medically underserved populations, compared to 24% of medical school graduates nationally. The conditional acceptance post-baccalaureate program is contributing to diversity of the healthcare workforce. 53% of conditional acceptance post-bac students are Hispanic Latino, 25% are Black African American, 10% are white, 9% are Southeast Asian, 3% are American Indian. Next slide, please. The program in medical education health equity is a mandated program by the state of California. Prime programs are at UC Irvine, which has a prime Latino culture, UCLA, prime leadership and advocacy, UC San Francisco, prime urban underserved, and UC Davis, prime rural health. These programs are partially funded by state budget. Since 2007, 134 students have enrolled in the Prime Health Equity Program. 81 students have completed the dual degree program and graduated. Prime Health Equity is addressing access to care. 69% of graduates are practicing in a primary care specialty, compared to 34% of medical school graduates nationally. Prime Health Equity is contributing to the diversity of the healthcare workforce. 28% of Prime Health Equity students are white, 27% are Hispanic Latino, 18% are Black African American, 15% are Asian, 11% are Southeast Asian, and 1% are American Indian Native Hawaiian. I want to re-emphasize that when we address the social determinants of health, we are addressing the adverse health outcomes that disproportionately affect members of the Black community. We are addressing the adverse health outcomes that affect oppressed, disenfranchised, and marginalized groups. And we are working to achieve social justice for all of us. Thank you.
Thank you very much, Dr. Daly, for this important glimpse at your leadership and the leadership of UC San Diego and the leadership of University of California system-wide in providing these important programs that advance diversity and equity and social justice. Our next speaker is Dr. Rodney Hood. After 40 years in medical practice in Southeast San Diego as a board-certified physician of internal medicine in CareView Medical Group, He recently merged his medical practice with San Isidro Health Centers. He co-founded and became president of an independent physician association, IPA, the Multicultural Medical Group, consisting of over 150 primary care physicians and 200 specialists managing healthcare plans and provider contracts. The IPA managed health services to over 25,000 enrollees, mostly from underserved communities. In 2012, Dr. Hood spearheaded a $1.2 million CMMI Healthcare Initiative Challenge Award that implemented a community-based social and clinical intervention strategy utilizing the hotspotting model referred to as the Patient Health Improvement Initiative, PHII, that focused on high utilizers of emergency rooms and hospitals and demonstrated cost savings of $15 million over 3 years. Over the past 30 years, Dr. Hood has researched and lectured extensively on the historic aspects of race, ethnicity, genetics, and racism in medicine and the impact on today's health inequities. Please welcome Dr. Rodney Hood.
You're muted.
Your mute is still on. Dr. Hood, your mute is still on.
Okay, can you hear me now?
Yes.
Okay, sorry about that. And I want to start out by want to make this talk in memory of Dr. Harold Simon, who was one of my life influences. I was one of the first African Americans to graduate from UCSD Medical School in 1973. I entered medical school as Rodney Hood and graduated Rodney X. Over there, is Dr. John McAdory and myself, who were the first African Americans to graduate. I state that because Dr. Harold Simon, who was founding member of UCSD Medical School, was also a major influencer in my professional life. Our initial relationship when I entered medical school was very toxic, but through the years, he continued to mentor me, and the talk I'm about to give actually started at his suggestion. As a medical student, he recommended that I research the origin of the sickle cell gene. So I'm going to talk about a hypothesis of post-traumatic slavery disorder. This is a visualization that I like. It was published in the Washington Post, where I think what it represents is, Black in a white hand saying, let's don't talk about race. Let's don't deal with the racial issues. I want to postulate racism and the ethnohistoric trauma suffered by slave descendants associated with the epigenetics and legacy of slavery produces an insidious chronic physiological stress we're going to refer to as allostatic load that causes increased risk for multiple chronic diseases, including cardiovascular disease, diabetes, cancer, and is a significant contributor to health disparities in this population, leading to early death. I want to thank Dr. Daly. I think her presentation was a good introduction as to what I want to talk about. She mentioned social determinants of health, which are conditions in the places where people live, learn, work, and play that affect a wide range of health outcomes. Many times when people talk about social determinants, they talk about the geography, education, job status, social economics. I'm going to focus on what do we mean when we say race, ethnicity, racism, bias, discrimination, because these are harder to measure, yet may have a more significant impact. And when we talk about these other social determinants, I'm going to conclude that these social determinants are actually racialized social determinants as opposed to happenstance racial determinants. So the history goes back many, many centuries. There's been centuries of scientific dehumanization of Black humanity. So not discrimination, not racism, but actually dehumanization. There was a scientist by the name of J.F. Blumenbach who postulated the natural variety of mankind, where he postulated that whites were superior, blacks were not as higher up on the hierarchical scale as whites. They actually used to teach in the science schools in the 1800s that measuring the facial angle, whites had a facial angle closer to 90 degrees, blacks close to 60 degrees, and apes less, suggesting their inferiority. We also have Dr. Cuvier. He was a French scientist who was fascinated by an African woman from South Africa, from the Koshan tribe. Her name was Satidra Barton. They called her a Hottentot Venus, large buttocks. They had a culture of dilating their vaginal area, etc. She was coaxed out of South Africa up to England by a physician, and Cuvier was fascinated by her body habitat, followed her around. They paraded her in Europe like a freak, and at her death, he made a model of her body, preserved some of her body parts, and used to teach using that, showing how inferior blacks were, dehumanization of women. We got Samuel Cartwright, who was a graduate of the University of Pennsylvania. He wound up down in Louisiana at the medical school in Louisiana, and his title was Professor Diseases of Medicine, Department of Medicine. Blacks were a specialty. There was a concern in Louisiana where slaves were running away. He actually did a study, published it in Du Bois Journal, determined that slaves were running away because they suffered with a mental disease called drapetomania, runaway madness. And some of the slave owners said, well, yeah, but he said, well, if you give them a little time off, some condescension, maybe they don't want to run away, because they, being inhuman, they felt that, hey, slaves should be happy being slaves. There were some slaves that no matter what you did ran away. And he said they suffer with a different medical disease called dysesthesia ethiopica, rebelliousness. Then we have Dr. Samuel Morton, who was a physician, University of Pennsylvania Medical School. He taught the theory of phrenology and craniology, where they would measure the skull capacities. And basically, whites had the largest skull capacity, followed by Native Americans, followed by blacks, postulating that, I call that the first Eurocentric IQ test. And then we got Dr. Samuel Knott, who was a slave owner and used to teach the theory of, quote, niggerology, that blacks' health was different. They didn't determine it to social determinants. They were just genetically inferior. And last, we have Dr. J. Marion Sims, who was considered the father of gynecology. He operated on slaves, 30 or 40 of them, many times before he perfected the procedure without anesthesia. I could go on. I suggest you read a book called Harriet Washington, called Medical Apartheid, The Dark History of Medical Experimentation, documenting many things that took place on blacks, not only slaves, but even after slavery. So when folks talk about the resistance of blacks to enter in the healthcare system, it is not just about Tuskegee and syphilis, it's centuries of abuse. This is from a book called An American Health Dilemma by Michael Bird and Linda Clayton. They point out blacks have been here for 400 years. From 1619 to 1865, that's about 62% of the time that blacks have been in this country, they've been in chattel slavery. From 1865 to 1965, about 100 years, that's about a 25%. That was during Jim Crow. And although we associate Jim Crow laws with the South, there was just as severe laws up north. And so although they were no longer slaves, they no longer had full rights. It really wasn't until the civil rights era in the 1960s where blacks began to get some citizens' rights. So that's only about 13%. And then today, we still have social injustice, health inequities. Dr. Burden Clayton talked about the disparities in health. They labeled it the slave health deficit, suggesting that these deficits go all the way back to slavery. I'm not going to spend a lot of time. This is the Institute of Medicine report in 2002 called Unequal Treatment, because in the 70s and 80s and 90s, there was just multiple reports and literature coming out showing that Blacks in the health system were being treated differently. This was one of the earliest studies in 1999 where they saw that Blacks were being treated differently, especially around cardiovascular disease. These are actually 8 actors who were posing as patients. They all were had the same script. Physicians, thousands of them, would listen to these patients, given the exact same history. They would make a diagnosis and then recommend what to do. Blacks with the same diagnosis and symptoms were recommended for less aggressive treatment than whites with cardiovascular disease. Now, when this took place, people were kind of perplexed as to why that was, because consciously, many of these physicians felt that they were not making a distinction between Black and white. And because these were actors, they all had the same, quote, insurance or whatever, they had eliminated a lot of other factors. So that brings us up to the 21st century, where we now understand there's something called implicit bias. And we can measure one's implicit bias in a certain test. And this is actually a study published in 2007 where they had young physicians, I believe, in Boston and Atlanta, and they did a vignette of treating a Black patient and a white patient. After measuring their implicit bias scores, the higher this number, the greater your bias against Blacks. The lower or 0, you have no bias. Below that, you have a pro-Black bias. And as you can see, Asian physicians, white physicians had the highest implicit bias towards Blacks versus others. And then what the importance of this is, this showed that your bias, because you have a bias, so this showed that physicians with a negative bias towards Blacks tended to make less therapeutic recommendations for Blacks compared to whites. So what I just showed you is there's been centuries of dehumanizations of Blacks, setting the DNA in America to kind of continue the structural suppression of Black folks. This has led to past and current events that increase our individual and collective toxic stress, causing, I think, 200 communities, cities, counties, states have declared racism a public health crisis. Disproportionate violent deaths among Blacks causing excess emotional trauma in Black communities and families. Yet, when there was peaceful protest in the NFL, they touted All Lives Matter, totally missing the point. Portrayed Muslims as terrorists, ignoring the fact that the majority of 1.6 billion Muslims are peaceful and family oriented. European immigrants have been welcomed for centuries. Non-European immigrants have been arrested and children taken away. In the past, turn of the century, white supremacists, KKK, they wore hoods. Today, they take off their hoods and invade the Capitol. Some of us define white supremacy as dysesthesia, caucasoid myopia. It is a mentality of misplaced arrogance supported by fake science, perpetuating false assumptions of superiority, leading to the creation and enforcement of laws, policies, beliefs, and biases that favor their advancement over other racialized groups. The impact of that on the minority, especially Black community, is that more so than your genetic makeup, where you live in your race, in your zip code, are more predictive of your longevity and your health outcome. Here in San Diego, 92037 is La Jolla. The average life expectancy of a baby born, 85 years. 92114, 92115. This is Southeast San Diego, central area, down where my practice has been for the past 45 years. Average life expectancy, 77 years and 79 years. So we have a very diverse country. And in 2011, the average life expectancy was 78.61 years. However, if we looked at that by various ethnic groups, the longest longevity is with Asians, 87.28, Hispanics, 83.48, whites, 78.74, Native Americans, 75.06, and the lowest is with African Americans. Why is that? I want to show this. Just recent studies said that from comparing 2019 to the first 6 months of 2020, due to COVID and worsening disparities, there was an actual decrease in the life expectancy of whites of 0.8 years, Hispanics 1.9 years, but Blacks 2.7 years. They were already only 74. I think I show this because this is a good example of what I think is one contributing factor is chronic stress. U.S. maternal infant mortality rates by race and ethnicity. As you can say, Black African-American mothers, their rate is 52.5, almost double that of the average of all mothers, and for infant mortality. And the significance of this is, yes, social status makes a difference. Blacks with the lowest social status have higher rates of maternal and infant mortality than Blacks who have higher rates, higher education and social status. However, when you compare whatever social status the Black mother is at to her white counterpart, it's still higher, and her maternal death rate and infant mortality death rates are higher. So why is this? Two concepts: adverse childhood events and allostatic load. Very quickly, early on, I think Dr. Here in San Diego at Kaiser in 1998 did a study on adverse childhood events, looked at thousands of Kaiser patients and measured their adverse childhood events such as depression, divorce, violence. And within that study, found that those with the greatest number of childhood events wound up with greater disease burdens, cardiovascular disease, diabetes, et cetera, as they got older, and earlier death. And this is the postulated formula. Within that subset, there was, they found that Blacks had higher ACE scores, adverse childhood experience scores, than whites. And then the concept of allostatic load is how we internalize our environment. So chronic insidious physiological stress causing wear and tear on body organs, leading to chronic disease. And these are like, you know, your exposure, your environment, poor housing, lack of social capital, poor employment, poverty. And then what's difficult to measure is racism. And I want to point out that when we talk about social determinants of health, I like to say social determinants of health for Black folks has been racialized social determinants of health. Poverty and the income gap and wealth gap were structured. There were policies that caused this. They weren't just happenstance. Poor housing, there was policies that caused that. So they were structural things put in there specifically keeping African Americans where they are. Many other communities who were in poverty were able to transition out. But because of the structural racism, it was much more difficult for Blacks. And real quick study, there are many now in the public health and behavioral health where they're actually measuring the allostatic load. And what they found is that whites had one of the lowest allostatic load. Usually if you're talking about whites or Asian or Hispanics, the male has a higher allostatic load than the female. However, in the Black, both of them had high allostatic load, but the Black woman had higher allostatic loads than the Black male. Blacks have higher allostatic load scores than whites and even higher than poor whites. Another lecture here, and I'm going to take a chance because I was raised with sisters, family of 9, and some of my family had straight hair. Some of my family had curly hair and had to use the iron. So I know women, Black women, there's the issues of hair, there's the issue of nose, there's the issue of skin color. And then there's the issue of raising Black children in America. All of this adds to the allostatic load. So in summary, Blacks have higher allostatic, have higher adverse childhood experiences, have higher allostatic loads, contributing to excess disease burden and shorter life expectancies. The toxic stress caused by chronic insidious racism includes the legacy of slavery and all the inhumanity, brutality that took place there, early onset of emotional toxic events that cause chronic allostatic load with micro insults, macroaggressions, post-traumatic slavery disorder. Thank you.
Thank you, Dr. Hood. We've heard about social determinants of health. We've heard now about historical determinants of health, and it comes back to stress, not just everyday stress, but toxic stress. And I really appreciate the way the previous 2 talks complemented each other in this respect, with social determinants and historical determinants of health for Black people. Our next speaker is Ms. Michelle Talley. She is a licensed clinical social worker whose main area of focus is working with youth and families as it relates to public child welfare. As a field consultant with the Inter-University Consortium, a collaborative effort of Southern California social work programs that trains social workers in the area of child welfare, Ms. Talley works with first and second year MSW students placed in the Los Angeles County Department of Children and Family Services. Ms. Talley has also worked as a mental health clinician dealing with children impacted by abuse and neglect within their family nucleus. Most of the children and families that she's worked with were also dealing with substance abuse issues, criminal problems, education, poverty, and mental health issues, which adversely affected their family dynamics. Ms. Talley has also worked as an adoption social worker with Los Angeles County Department of Children and Family Services. The focus in this work was to locate families and individuals who were interested in providing a permanent home for children in the child welfare system. We welcome Ms. Michelle Talley.
Thank you so much. I'll go ahead and share my screen. So go ahead and get started. I'm going to be cognizant of time. So I wanted to talk a little bit about the intersection of runaway foster youth and as it relates to sexual trauma and violence. So the agenda, just talking about some of the factors related to runaway youth in foster care. And then we'll also talk specifically in sexual trauma, talk about human sex trafficking defined. And I want to highlight that I want to talk about specifically domestic sex human trafficking of foster youth. So each year, almost 500,000 youth in the United States experience foster care placement. So if you think about it in the United States, that's a significant number. And they're primarily in family foster care settings. So that could be anything from a grandmother taking care of a child, to a cousin, to an adult sister, and then you have foster families that take care of foster youth. And then ultimately, if they're not able to manage in those settings, they'll end up in group homes or residential treatment center. The national data of foster care show that approximately 1% of the youth in foster care were reported being on runaway status at the end of 2018. And so for the sake of this presentation, we're going to focus on the runaway youth in foster care. It's also reported that, so once a youth runs from their foster care placement, they can remain a runaway anywhere from 24 hours to even months, and in some cases years. Some of the factors associated with runaway behavior. So if we look at age, so with age, the average age of youth running away, it usually increases during the adolescent stage, with the highest age between the ages of 14 and 16. And some of the reasons you can think about this, if you think about Erik Erikson, developmental theory, at that time, children are seeking to achieve autonomy. And then also, there's also a lot of self-exploration and risk-taking behaviors. If you look at females are more likely to run away from foster care placements compared to males. Now, again, I'm talking in a binary format, just understanding that it's not always the case. There could be non-binary foster youth as well. And then if you look at race and ethnicity, there's an increased risk of running away amongst minorities, non-white youth. And as the other two presenters highlighted, African-American youth are disproportionately placed. So this is where I want to go back. African-American youth are disproportionately placed in residential placement, which is a high risk for running away behavior. So at the time that Child Protective Services enters in a family's life, oftentimes African-American children are placed outside of their home, whereas white youth are usually, services are provided within the family system. And then there's more effort being put to keep the family together. And then if you look at sexual orientation and gender, LGBTQ youth are more likely to run from home, their home of origin, as well as the foster care system. Also, one thing to note is LGBTQ youth are more likely to end up homeless from their home and foster care at higher rates than youth that identify as heterosexual. Continued factors associated with runaway behavior, substance use. So there's substance-related disorders, including alcohol, are also a risk for youth running away in foster care. Mental health, there's also evidence, although the evidence is mixed, but there are some studies that show that there's a correlation of mental health diagnosis and an increased risk of runaway behavior. Child welfare experiences, also we want to look at history of multiple placements. So as I mentioned in the earlier slide, African American or Black youth have higher rates of having multiple placements or being placed multiple times in child welfare as opposed to other youth. And so that's also a factor. The history of multiple placements is associated with youth running from care. And so every additional placement seems to correlate with increased risk of running away episodes. So you might ask, why do youth run from foster care? So there's some push factors that we can look at or think about. So they may be escaping from an unsafe situation, maybe in their own home. Maybe it's unsafe in the foster placement or in the residential placement that they're in. There are times where placements could be overcrowded. There's also oftentimes highly restrictive rules, and they're highly restrictive and not necessarily being able to do things other than within the group home or within the residential treatment center. Some of the pull factors can include that youth are also looking to gain access or gain reconnection to their family, friends. They may also have romantic partners that is pulling them away from their current placement. And then also we want to also think about youth also want to maintain a connection to the community of origin as well. And then they also could be seeking some sort of sense of independence, so as some of the pull factors. So some of the consequences of youth running from foster care, I know it was brought up, but some of the consequences is that youth, runaway youth have poor health outcomes. They have an increased probability of substance use. It's highly likely that they are underperforming in academics. With also that being said, there's also a probability that they can become in contact or intersect with the juvenile justice system. So it's likely that youth that run away also end up with multiple system involvement, including the juvenile justice system. And then there's a high probability that youth can also experience sexual victimization, including human sex trafficking. So I want to really highlight. Go back 1 second. So I want to really highlight on one of the consequence, just for the sake of the time, is I want to highlight on the sexual victimization, including human sex trafficking. So I want to talk a little bit more and delve into that a little bit more as it relates to foster youth who run away. So human sex trafficking defined. The legal definition says that sex trafficking is a commercial sex act as defined by the Trafficking Victims Protection Act, TVPA, induced by force, fraud, or coercion, or in which the person induced to perform such acts has not attained 18 years of age. So I just want to really also highlight is that anyone under the age of 18 it's illegal to consent for or to participate in human trafficking. Some of the basic definition of human sex trafficking defined. It's also the use of force, fraud, or coercion to induce labor or commercial sex acts in exchange for something of value. Sometimes it's money, but if you think about a runaway youth, sometimes it could meet their basic needs as well. So sometimes runaway youth also exchange sex acts for a place to stay, for food, just to meet their basic needs as well. Also, inducing a minor less than 18 years of age in commercial sex acts in exchange for something of value. So it could be something of value as well, regardless of force, fraud, or coercion. Some of the terminology, some of the familiar terminology that you might hear and that might be used as it relates to human trafficking victims. You might hear sex trafficking, child sex trafficking, commercial sexual exploitation of children, domestic minor sex trafficking. While youth and individuals are in the life, or while they are in a victim of, or while during their exploitation, they would be referenced as victims. And then after exploitation, so after youth or individuals leave the life, and it usually takes approximately 7 times for a youth or an individual to leave the life, then then you would reference them as or label them as survivor. You might ask, but who are these? Who are they? Human sex traffic victims. Who are they? So they could range from all different kinds. Not all different. They can come from all different groups. They can be people experiencing homelessness, as I just mentioned. They could be people, youth of color. They could be LGBTQ youth, as I highlighted, runaway youth. They could also be youth in the foster care system. They could also be youth in the criminal justice system. You could also think about youth that have previous histories of abuse and prior victimization. So there's a correlation between youth who have been exposed or experienced sexual abuse or some sort of abuse and neglect, there's a correlation to them being at an increased risk of being a victim to human sex trafficking and exploitation. It could also be residents without citizenship. It could also be boys as well. One thing I want to note about that is that there is not a lot of research and not a lot that we know about boys who end up being trafficked and or exploited. The one thing that I do know is oftentimes the little that we know, oftentimes these are young male youth who may be questioning they may be questioning their identity, or they may be coming out and they're not accepted in their home environment, or they may not be accepted in foster care. And so we know that they have higher risk of being homeless and or runaways, and there's a higher risk of them succumbing to being a victim of human trafficking. And then I just also didn't want to leave out that adults also could be victims of human trafficking. And I want to also note is that I'm talking about domestic human trafficking. We know a lot about, and when we think of sex trafficking, we think of individuals outside of the country, maybe in India or Thailand or Africa or someplace like that. But I'm talking about these are individuals who live in the United States. I also wanted to highlight some of the continued risk factors. As I mentioned, a history of child sex abuse. They also could have a history of physical abuse. Poverty is another factor, as the two other presenters really looked at economic injustice. And then there's substance use either by the youth and or the caregiver. So there could be substance use in the home by the caregiver that also is a risk factor for youth potentially being victim of human trafficking and exploitation. Possibly a loss of a parent or caregiver, runaway, also sometimes how they're mentioned is being thrown away. Oftentimes, especially in the child welfare system or in the juvenile justice system, if individuals or if youth repeatedly run away or repeatedly leave their placement that they've been assigned to, then oftentimes they're looked at or seen or labeled as thrown away, which is not appropriate, but that is sometimes how they are viewed. Also, you can think about some of the risk factors, continued risk factors is the lack of support system. So oftentimes these youth may have strained relationships with their family, or maybe inconsistent relationships with their family, or maybe their family is the one that they also experience abuse and neglect within their family system. Sometimes these individuals are at risk, youth that have special education needs or that have special needs, system-involved youth. I also want to talk a little bit about technology as a risk factor. So being that technology, now we're in the age of technology, the same platforms that are used for individuals to meet or to connect with other individuals, maybe locally or nationally, are the same platforms that are used to recruit individuals for human exploitation. So an example of that is if you're aware of Backpage, that was used at one point to recruit young individuals into human sex trafficking. And oftentimes it's a lot harder to detect youth that are in or individuals that are in human sex trafficking, because not only are they recruited on the technology platform, but they also deals are made and connections are made through technology. So it's a lot harder for law enforcement to detect. And then I wanted to also talk about there are times where the gang participation. So sometimes it's a gang initiation for individuals to participate in the gang. They have to also participate in human sex trafficking and exploitation as well. So these are all risk factors. Wanted to just talk about the characteristics of the trafficker. You might think about, well, who are they? Sometimes you have one of the characteristics is a Romeo boyfriend. They're very charming, giving positive attention. Oftentimes, especially if you think about runaway youth, they're giving them attention that they didn't get in their placement or from their family. There's also branding. So there's also times where the individuals are branded and they belong to that pimp as well. So that signifies that they belong to that pimp. There's also grooming, and when a characteristic of a trafficker is grooming. So there's a lot of secrecy. They're breaking down the victim's self-esteem, and the victim eventually feels dependent on the pimp. And then there's the CEO trafficker. They make all these false promises. And oftentimes it's a business in disguise. So they'll say, you know, I want to recruit you for modeling, or I want to recruit you to be an actor, or I want to recruit you to make sure that your dreams come true. But all of these are just a ploy for them to then become a victim of human trafficking. And then there's guerrilla, which is it's very rare that happens, but this is what you usually see in the media: the forced kidnapping, the drugging, and the isolation and the violence, and they have no freedom. So that's what you see more often, but that's the least common characteristic of a trafficker. There are some facilitators. So there are some people who also will contribute to youth being trafficked, families. So there could be intergenerational experiences of human trafficking. So you have families that will recruit or will sell or will participate in human trafficking when it comes to their children. And then children are exploited at very young ages. The youngest age that I'm aware of was 5 years old, and they could be trafficked all the way through till young adulthood. Parents are also traffickers too, especially in rural areas. There's also peer pressure. So if you see right now it's COVID, but you also will see peer pressure. You'll see peers recruiting other peers in the school setting, in those group home placements that I talked about, and in residential treatment centers. And then you have youth's curiosity. And then what also happens is that it's a lack of financial resources. So sometimes you see youth wanting a way to make money to support their family and their financial circumstance. As I mentioned, internet-based, some of the recruitment is a platform, social media, false advertisement, also location sharing. So youth are more likely to believe the internet and feel it's a safe place to meet people. So that's one of a tactic of recruitment of youth in human trafficking. What I wanted to move a little bit is that the youth that are human trafficked and are exploited, there's a great public health significance. They have higher rates of STI, HIV, pregnancy, and sexual risk taking. There's higher levels of substance use disorders and or excessive substance use. There's higher rates of post-traumatic stress disorder, anxiety, and depression. And then there's often histories of maltreatment and child abuse prior to sexual exploitation. And then there's also frequent contact in the juvenile justice and foster care systems. What do we do? So maybe you asked, wow, this is a lot that we just said over the last few minutes. What do we do? One of the things you want to do is you want to report to local law enforcement, and you want to specifically ask to speak to the Human Trafficking Task Force and or VICE. You can always call the National Human Trafficking Resource Center and report trafficking, or you can get more information on trafficking. So the number is there, or you can also text help. You can also call the National Center for Missing and Exploited Children. You can report child sexual exploitation by using the cyber tip line, 800 the lost. And then there's also a human trafficking database.com that you can get more information and resources on human trafficking. So thank you for your time.
Thank you very much, Ms. Talley, for this ground level view of the many factors that are involved in threatening and challenging the well-being of these runaway youth. Our final speaker today is Dr. Seth Hannah. Dr. Hannah is our academic coordinator for the Masters of Arts in Global Health program here at UC San Diego. He's been with the Global Health program since fall of 2019. Dr. Hannah is a sociologist specializing in how race, ethnicity, and culture shapes the delivery of healthcare. He has earned his PhD from Harvard University in 2011 after completing a predoctoral training program in inequality and social policy from Harvard's Kennedy School of Government and another in culture and mental health services from Harvard Medical School. He's currently studying the dynamics of medical interpreting in community health settings, the different ways diversity impacts healthcare in the United States, Switzerland, and Canada, and the experiences of fatherhood among formerly incarcerated African American men. Please welcome Dr. Seth D. Hannah.
Thanks, everyone. Let me share my screen. Okay. Thank you all. So good afternoon, everyone. Thank you so much for inviting me to be part of this really outstanding panel to discuss a topic that's been central to my own academic work for nearly 15 years now. Like Tom said, I'm a sociologist, but I've also been trained in medical anthropology, and I approach our topic of health and justice in the Black community from an analytical and theoretical perspective. I really see my role as using research to help us better understand how unequal treatment is generated, the mechanisms that generate it, and use the answers to develop solutions that will improve healthcare and ultimately the health of Black Americans and others in the country who are subjected to stigma and discrimination. So what causes unequal treatment? In my eye, the fundamental causes of healthcare inequality in the Black community are concentrated poverty and racial segregation. The distribution of resources and opportunities available to Black Americans varies dramatically across geographic space, as shown by the map here. Which is put together by the economist Raj Chetty. Raj Chetty, using big data to study intergenerational mobility, shows how difficult it is for children who grow up in concentrated poverty environments to earn more money than their parents. The map shows how well children who grow up in with low-income parents are able to move up the income ladder as adults. And this varies dramatically by neighborhood, as you can see by the color codes here on the map. With children raised in lower income communities having the most difficult time achieving social mobility and exceeding the status of their parents. So Chetty and a long line of sociologists, such as William Julius Wilson, who's my former advisor, and Douglas Massey and others, have shown that neighborhoods dramatically structure our life chances, including the availability, access, and quality of care available to the local population. So you might ask, how did it get this way? Why are some neighborhoods so much more disadvantaged than others? And how does this affect health and healthcare? Well, the answer lies in a complex interaction between race and class. Since the 1970s, poverty has become concentrated in racially segregated environments. This has led to dramatic declines in economic and public sector investments, leaving the health infrastructure dramatically neglected. Now, this neglect of public infrastructure in poor, racially segregated communities has become evident during the COVID-19 pandemic, as prominently reported in the pages of the New York Times in recent weeks. King Hospital has long been the subject of protests over neglect and poor funding, which local activists maintain is directly related to racism targeted at the large number of Black Americans that have long called South Los Angeles home. The Times reporting illustrated that the lack of treatment capacity and availability of effective therapeutics at King has caused a huge excess loss of life in that community. In places like South Los Angeles, you have to look at the history of what has happened there. Racist behavior by the real estate industry, racist desires for whites-only housing, and government policies that allowed and facilitated those behaviors all combined to produce racially segregated patterns of settlement that have even endured as the overt practices of discrimination were made illegal with the civil rights actions in the 1960s. Now, another factor that we really need to consider here is the economic transformations that have taken place in the United States in the post-civil rights era. I'm talking about deindustrialization, globalization, and the favoring of high-skilled work. This has led to a decline in high-quality jobs for all lower-educated Americans and has resulted in a dramatic concentration of poverty in similarly segregated communities all over the country. It's the fusion of the economic changes with the segregation that intensified the challenges that communities face. This depleted the tax base and made it much more difficult for public resources such as hospitals to serve the needs of the population at the exact moment the ability to maintain good health was becoming more difficult due to increasing poverty, police surveillance, and violence. So it's these ecological challenges fueled by racism and macroeconomic conditions that lead to persistent intergenerational patterns of disadvantage as children struggle to secure better incomes and living conditions than their parents. So it's deep structural change that reduces poverty and improves opportunity is what's really needed to improve the conditions of daily life and to improve the quality of healthcare available in communities where large numbers of Black Americans live. Now, healthcare providers can serve an important role to mitigate these challenges, yet they often intensify them. Black patients are subjected to generalized prejudice and negative affect during their interactions with administrative and clinical staff when they go to seek healthcare. They're also gazed upon by staff with a specific set of stereotypes related to widely circulated views of Black people held by society. And another specific set of stereotypes related to their medical training and the data that doctors acquire from their training about the frequencies with which Black Americans suffer from certain diseases and ways that Black bodies are purported to work. These views may be accurate assessments of broad differences between groups, yet they fail when applied to specific individuals due to the inaccuracy of racial categorization and the weakness of physical markers to accurately provide a guide to meaningful human biological and genetic variation. Physicians of all backgrounds rely on these epistemological shortcuts to make vital diagnostic and treatment decisions, often under great time pressure. Black patients are poor. Black patients are non-compliant. Black patients are not trustworthy. Black patients don't feel pain the same way that white patients do. Research suggests these attitudes are widespread among clinicians, even if they think of themselves as equitable, dedicated professionals. After all, why would a doctor be racist? Sadly, some of these are acquired through lifelong socialization, but even more worrying is that they are often embedded in medical school training curriculum. All these factors were likely at play in the tragic case of Dr. Sandra Moore, who sought care for her COVID-19 infection, carrying all the health literacy and insider knowledge of the health system that you would expect from a highly trained and successful physician. Yet this was not enough to buffer her from the stigma she carried as a result of her race and her gender. Her pain was disbelieved. She was not taken seriously or given proper attention and treatment that she deserved, and she ultimately passed away. This shows that addressing the plight of the Black poor is not enough to reduce health disparities. High SES Black patients do not escape stigma and discrimination and continue to see their healthcare suffer compared to equally advantaged non-Black Americans. Dr. Sandra Moore's case also shows us that bias is multidimensional, as she was likely viewed through the lens of stereotypes about her gender as well as her race. In my own research, I observed administrative and clinical staff speak about and treat patients according to their false beliefs about that patient's race, ethnicity, immigration status, gender identity, cultural views, language skills, social class, illness status, and even their behavioral profile. For example, where they seemed too rowdy, or whether or not they grew up in group homes, or whether or not they're likely to be druggies. In psychiatric clinics I observed in Greater Boston, Black patients were often stereotyped and treated differently than other patients, but there were many other micro-emergent categories of difference that generated significant bias and unfair treatment in that particular clinical setting. So we need to recognize that the power of race to shape clinical interactions is greatly variable. And we need to consider the full range of potential sources of bias and seek to discover the conditions under which they become more or less significant in different settings. And so it's important to acknowledge that the multidimensional forms of bias I'm speaking of can be conscious or unconscious. And I appreciate Dr. Hood brought up this topic. Certain forms of bias are more openly accepted than others, leading people to deny their negative feelings towards some patients and readily admit them with regard to others. For example, bias against patients who are overweight or who are living in poverty is frequently expressed openly, even by clinicians, while bias against racial minorities is verboten. This makes it difficult for researchers to discover the prevalence of bias in clinical settings. Measures of implicit bias, such as the implicit association test or IAT, are seductive in that they purport to reveal the truth about how physicians feel about their patients, even if they are not even aware that they have those biases in the first place. So the widespread use of the IAT in studies of health provider bias has really had mixed results. However, some studies, actually many studies, have showed that doctors with more implicit bias are more likely to discriminate in their daily practice, those audit studies and those actors that Dr. Hood spoke about before. So these findings, there's other studies that have shown some mixed results and contrary results. But in general, this is kind of an in vogue thing, right? The whole idea of unconscious bias has generated buzz and headlines, giving the impression that most, perhaps, of our modern problems with race can be reduced to widespread unconscious bias. After all, it's everywhere. We don't do it, it's not our fault. It's just there. I think this is folly for a number of reasons, but let me tell you about the research I conducted where I observed a medical school course to reduce unconscious bias in medicine. The course contained a series of lessons and group exercises that encouraged senior faculty at Harvard Medical School to introspect about their own identity and reflect on how their blind spots might lead them to unknowingly treat some patients with antipathy or engage in other biased behaviors in their relations with patients and colleagues. The objects you see here in the slide are from the totem exercise, where participants were asked to bring in a personal item that symbolizes their identity and share what it means to them with the class. And so if you look at the picture here, you'll see a picture about the Black Holocaust, you'll see a New Yorker magazine, you'll see personal letters, you'll see pictures of where somebody grew up. The interesting thing about this exercise is that instructors of color frequently brought things that symbolized their identity and their background and their nationality, whereas faculty from European backgrounds brought things about their hobbies and their interests. The New Yorker, they're an intellectual, right? It's very interesting how people configure their identity. The class featured some great education about the different barriers that patients might face in their engagements with providers and raised awareness among the faculty that their behaviors may harm patients, even if they don't realize it. More troubling, the course cultivated a sense of absolution among the faculty participants, that their behaviors were just unconscious and that they really didn't have much control over their actions. The course was geared more towards public catharsis than developing the habits and routines that might prevent their bias from actually harming their patients. What is more, the course was voluntary, so the clinicians with overt bias or no desire to improve their relations with patients would never even sign up in the first place. This unconscious bias approach then ultimately ignores continuing overt bias and doesn't do anything to address the other sources of unequal treatment, namely concentrated poverty, racial segregation, and the racial barriers to social mobility. Finally, I want to address another important source of unequal treatment that often goes unnoticed by health disparities scholars. As I've discussed during my talk, The history of systemic racism and contemporary patterns of health provider bias both combine directly to reduce the quality of healthcare available to Black Americans. But there's another seemingly non-racial force that indirectly generates unequal treatment. I'm talking here about the culture of medicine itself. That is, how medicine is practiced, what values it holds dear, and the way it generates knowledge. These aspects of the culture of medicine can themselves create lower quality care for some patients and advantage others. Let me tell you a little bit why. Medicine in the US is a business, and its corporate reorganization in recent years has put profit over people. This means that the length of patient visits have been cut, technology is used to mediate patient interviews, and the work of doctoring is structured by compliance with standards and health insurance oversight. This places clinicians under great pressure to elicit precise information that they need. And in the case of physicians, they need clear indication of the physiological processes underlying the patient's complaint. Right? It's the medical gaze after all. Black patients, especially those from disadvantaged backgrounds, frequently live complex lives and have difficulty communicating with their physician due to their underlying distrust of medicine and fears that they're going to be treated unfairly by their provider, rightly justified fears in many cases. This means that their attempt to tell their story may not fit into the medical machine, the highly structured process of clinical interviewing held dear by providers. Any attempt to contextualize their experience with details about their social life is at risk of being seen as inadmissible evidence by the provider. This leads to inaccurate diagnosis and poor management of treatment course. Next, probabilistic thinking, right? The epistemological source of medical reasoning is the root of medical reasoning, but it fails to apply when looking at demographic populations. Obviously, you need to understand trends, you need to project those trends and generalize from them. But when you do that to individuals, to an entire background of people, an entire demographic, right? They use that as a quick shortcut to help reach their differential diagnosis. But unfortunately, individuals do not match up quite well to the basic forms of racial categorization that are social, not biological in nature. Race is an incredibly imprecise proxy for underlying biological variation, yet medical training relies on demographic variation to help doctors more quickly reach their diagnosis. This can lead them to over-focus on conditions that are common among Black Americans and neglect rarer sources of disease that lead to misdiagnosis and deadly delays in treatment. Finally, the culture of medicine places physicians, especially specialists, at the height of the medical hierarchy. Yet they often have the least amount of contact with patients and know the least about the social conditions under which they live. This leads some primary care practices to silence the voice of complementary staff that could contribute meaningfully to patient care. For example, in my research examining the role of medical interpreters in community health centers, I found that some physicians only wanted interpreters to be a voice box and directly translate what patients said word for word. In other clinics, they frequently consulted with them to get their cultural insights on the patient's experiences, understanding that they frequently come from the same communities as their patients and spend time with them before and after the visits. This gives them meaningful insights as they engage in those kinds of casual conversations. Unfortunately, those contributions are ignored. And so strict adherence to medical hierarchy can actually generate inferior patient care. Last slide. So what do we do about this? How can we improve care? And I've seen some questions in the Q&A about solutions. So let me talk a little bit about that. Now that we have a better understanding of the healthcare challenges facing the Black community in the United States, we can begin to suggest strategies to improve care and reduce disparities. Considering the fundamental causes of concentrated poverty and racial segregation, we need an active effort to spur tight labor markets and economic development in ways that will improve the health infrastructure in the most disadvantaged communities. And considering the discrimination in healthcare experienced by Black Americans at every level of the income and wealth distribution and the multidimensional sources of stigma that intersect with one another, we need to recognize and address health provider bias in ways that go beyond simple anti-racism training or unconscious bias training. We need to create strong standards, routines, and systems of accountability in order to maintain equitable care. It's about the results. It's not about changing hearts and minds. It's about demonstrating results and generating consistent treatment for all, regardless of their backgrounds. We should also recognize the growing hyperdiversity within the Black community. In Boston, more than a third of the Black population is foreign-born, and 40% identify as having West Indian, Haitian, or Sub-Saharan African ancestry. This means that cultural competency training that seeks to educate providers about the characteristics of their patient populations ahead of time will be insufficient and likely impossible due to the explosion of hyperdiversity and the unlimited intersecting identities that we all hold. In my research with the health program for African refugees being resettled in Boston, I found that even a seemingly discrete group like the Somali Bantu that you see here depicted on the screen defied categorization and contained significant cultural and identity variations that went against the pre-distributed manual intended to help providers understand their needs. Finally, considering the role that the culture of medicine can play in generating unequal treatment in the Black community, we need a sustained effort to transform our healthcare system to become more patient-centered so that the unique needs and social conditions of all patients can have the space to be taken seriously. The social and structural determinants of health need to be brought to the center, and we should replace efforts to become more culturally competent with efforts to become more structurally competent. Thank you very much.
Thank you very much, Seth. What a marvelous set of interlocking and complementary talks that we've had. We have a few minutes left for about 10 minutes left for questions and answers. And I want to start by reading a question that's come in from Professor Janice Jenkins, who's the director of the Center for Global Mental Health here at UC San Diego. Her question goes as follows. The intersection of endemic racism in the US and social discrimination against persons struggling with mental health issues is important. We have seen police murders of far too many Black US citizens, including Daniel Prude. Many people knew this story and are outraged, certainly I am. Mr. Prude, highly distressed and apparently in a psychotic state, left his family's home and went out at night into the freezing rain, naked and agitated. He smashed some store windows. The local police from Rochester, New York were called and came to the scene demanding that he lie on the ground, which he did immediately with his hands behind his back. The police officers put a mesh hood over his head, allegedly because he had been spitting, and he was asphyxiated, dying days later in the hospital. While he was on the ground struggling, the officers chuckled, appearing to find the sight of a mentally ill Black man amusing. While the Rochester Police Commissioner was dismissed, yesterday the officers who murdered and mocked Daniel Prude for the intersecting crimes of being Black and mentally ill will not be charged for those crimes. I'd like to ask the panelists, anyone who might wish to respond, to comment on this crime, the intersection of being Black and mentally ill. Thank you.
I mean, I'll just say a couple of things about that. Historically, Blacks who have a mental illness, one of the largest housing places for Blacks or people of color and mental illness is jail, and or they succumb to murder. I think, again, it speaks to what Dr. Seth Hannah mentioned, is that we really need to look at the structural inequalities and some of the ways that we are socialized to view Blacks and to view Blacks and the intersection of mental health conditions. I think we need to start there and really look at how it's accepted that a Black person with mental illness can just be laughed, mocked at, and then ultimately killed, at the hands of law enforcement. And there's many counts of that other than the one that was referenced.
Thank you very much. I have, while you have the floor, Ms. Talley, there's a couple of questions that came in directly, I think, for you, which are, what other countries besides the USA would you say has the largest trafficking of victims? And a separate question, what does the process of establishing trust with runaway youth look like?
Okay, so the largest, one of the largest human trafficking, we know India is the large human trafficking, Thailand, and then some parts of Africa. But I really want to say human trafficking is everywhere, and it has been everywhere for centuries. It's just been we're more aware of it domestically. As it relates to runaway youth and how do you build rapport, the one thing that that is important is to really show empathy and show a sense of care, and not necessarily look at their behavior and you're quick to penalize or be punitive of their behavior. It's really just taking a look at the person and their circumstance that led them to their runaway behavior. And then that's how you begin to build a rapport. It's just really accept and begin to develop the relationship by being accepting and understanding that their behavior is a symptom of something else.
Thank you. Here's a question for Dr. Hood. It says, would you say there is a correlation between, it looks like misogynoir and medicalization? And to any speaker, do you believe that medical academia recognizes the negative history, the negative medical history, as it's been perpetrated on Black people?
So I think, I really think physicians and people in this country really need to get re-educated about the true history. And I think that will kind of make folks understand that what's happening today is very predictable. For instance, even before COVID, it was clear to many folks that any catastrophe like a pandemic was going to impact people of color, low economic status, and Blacks greater than anybody else. And so when it happens, people act surprised and ask the question, why are Blacks more affected by this? The earlier question about the how police treat Blacks, that goes all the way back to slavery, where policing actually started during slavery, trying to keep slaves from running away. The recruitment to many police forces have brought in some of the most racially biased individuals to control that population. So I think it's historic, and unfortunately, that's not something that's taught. I think physicians and healthcare professionals really are not aware of the medical history. Many of the individuals that I pointed out in the as perpetrators of dehumanization of Blacks were praised in medical history as pioneers in health, Dr. Sims, et cetera. So there's been a Europeanization and whitewashing of the history, making what took place during slavery not seem as bad as it was. And so I think more so with our children, we need to start educating them about that history. And then I also state that most patients in this country are not taken care of by Black physicians. So even if one of the solutions is to increase the pipeline, the other physicians that are not Black, it doesn't mean that if you're not Black, you can't take care of Black patients. It just means you need to have a real equitable lens. And I know patients they talk about the triple aim, quality, access, and efficiency. Patients also have a triple aim. They want to make sure that the doctor knows what they're talking about, quality. They want to know, can I trust this person? And more importantly, compassion. Does he care about me? And if you meet those three criteria, I don't care what color the patient is, you can transcend the relationship.
Thank you. Rachel Yim is observing how Dr. Hannah's talk highlights aspects of the hidden curriculum that's not being addressed by surface level curricular changes in medical school. Clearly, curriculum change is not enough. It's a tiny layer. No one teaches doctors to be racists. You learn these racist ideologies from unsaid cues and unspoken rules. Do you think reform is enough? What do you think medical students can do within these capitalistic frameworks?
I can speak a little bit to that. I agree that the hidden curriculum is real. People bring biases that they've learned throughout their life, but also I think bias is contextual. I think that certain situations intensify and bring out bias that's relevant to the type of work that's trying to be done in the moment. So what we found in a lot of our research settings is that things that really matter to getting the work done of doctoring that really frustrate medical practice generate really intense negative attitudes towards anything that gets in the way of accomplishing that goal. And so categories of difference will emerge that really stigmatize certain types of patients that make it very difficult. So the whole idea of the train wreck patient, the difficult patient that is not behaving in ways that make it easy for them to accomplish their work. In the inpatient unit that I worked, it was a very violent place. It was a private inpatient psychiatry clinic where patients would be very, very violent. And so surveilling and managing intent to be violence, triggers for violence, likelihood for violence led doctors to create a whole series of subtle indications that might mean danger for them. And so they were hyper vigilant about recognizing those, and they named them and they identified certain patients according to these types of ideas. And so I think that we need to think more situationally about what's going on instead of trying to build programmatically a whole set of trainings that we could universally send all the way around. That would be my initial read on it. And as far as the capitalistic part, anything that you can do to create space for yourself to practice in a more free way, you have to find ways to do it. Otherwise, if you're stuck in the high pressured system of modern corporate medicine, it can eat you alive. I've seen young doctors really burn out and have really intense breakdowns because of what they're going through and how hard it is to practice today. So I wish you luck. Work on health reform.
Thank you. I also see the question by Jasmine Ballard, who points out that Black and brown doctors can possibly unwillingly develop bias toward Black and brown people themselves. That's an important observation, I think. I want to squeeze in one last question since we're out of time. And this is a question of my own. Dr. Daly and I had an exchange by email in the process of inviting her to participate that juxtaposed the idea of racial justice and social justice. And I'm wondering if that distinction is something that we need to unpack. A distinction between racial justice and social justice, or an intersection between racial justice and social justice. Does anyone have any thoughts about that issue before we close?
I'd like to say that I think in my brief talk, I addressed the fact that social justice is the overarching umbrella. In looking at the social determinants, racial justice is one of the social, environmental, economic determinants that we must address. Once, as long as we're addressing the determinants, no matter where you begin to address it, you are participating in the work of moving our society closer to the overarching umbrella of social justice for all of us. And that's sort of the way I would unpack it. Their terms, they are defining where you're working on race, you're working on poverty, you're working on health, and we're all moving towards social justice for all of us.
Thank you very much. I think that big picture look at the broad umbrella of social justice is a good theme to take us out for the afternoon. I am incredibly grateful to all of you, and I want to turn things back over to Rola to wrap things up for us.
Thank you, Dr. Shordash, and thank you to all of our wonderful speakers. We are honored to have you and for everything you have spoken about this evening. As a reminder, the extra credit form and the attendance form have been posted in the chat. And for those asking about the recording, we will be sending out the recording through email. It will be posted in the newsletter as well as the Global Health blog. So keep posted for that. And I would like to thank you all one more time and have a wonderful evening. Thank you all.
Thanks, Rola.